Hi friends, greetings of the day. Today we will discuss about a topic called Polycystic Ovarian Syndrome. Uh, Polycystic Ovarian Syndrome is an hyperandrogenic state. Means this is a condition in which there is increased levels of androgens, that is male hormones like testosterone or dihydroepiandrosterone, which is also called DHEA, and dihydrotestosterone. All these are androgens. So in this polycystic ovarian syndrome, there is increased levels of androgens. It is in hyperandrogen states. Androgens are male hormones like testosterone, DHEA. In this condition, we will see multiple cysts, ovarian cysts, polycystic. So multiple ovarian cysts are seen in the USG, but it is not a compulsory. But in many women, around 75 to 80%, you can see ovarian cysts more than or equal to 12 immature follicles. That is, multiple ovarian cysts can be seen in these patients, but it is not a mandatory for diagnostic criteria. Main thing is hyperandrogenic state is an important. This patient typically presents with hirsutism, irregular periods, means irregular menses. Hirsutism means male pattern achievement of hair growth, male pattern hair growth like beard, mustache, etc. And excessive hair growth on the body will be seen. That is hirsutism. Irregular periods will be seen, irregular menstruation, and acne will be seen, infertility will be seen, and in some patients there will be amenorrhea, means they will not get periods properly due to anovulation. This is a condition where the ovulation is not achieved properly. Because of that, it will lead to infertility and primary amenorrhea, also lead to amenorrhea, and also irregular periods. So they will present with hirsutism, irregular periods, and acne, infertility, in primary amenorrhea, and also sometimes they will have masculinity, increased masculine muscles like men, and also they will have male pattern baldness, and also they will have the voice like men, like males. Okay. And pathophysiology is mainly these patients are obese. Okay. And also there will be not only obesity, there is a genetic predisposition for this PCOD, means in twins and also in the family they will be having this PCOD. Okay. Because of obesity, overweight, these patients will have insulin resistance, means insulin will not act on the insulin receptors. Because of that, the glucose levels will increase. Okay, glucose levels will increase, and they will have impaired glucose tolerance test and type 2 diabetes mellitus. When these insulin resistance is there will be increased levels of insulin. Because of that increased levels of insulin, there will be decreased sex hormone binding globulin, which is also called as SHBG. Normally this testosterone will be binding to this SSBG in the body, but when SHBG is decreased, the testosterone bind to this SHBG will come into the circulation, and there will be increased levels of free testosterone. So because of this insulin resistance, there will be increased insulin levels, leading to decreased SHBG, leading to increased free testosterone. Okay, and due to insulin resistance, there will be increased levels of lipids like triglycerides and cholesterol, leading to dyslipidemia. Okay, mainly the pathogenesis is in some patients there will be genetic predisposition, and in many there will be obesity leading to insulin resistance, leading to increased levels of insulin, leading to decreased SHBG, which leads to increased free testosterone. The insulin resistance will also lead to hyperglycemia and type 2 diabetes mellitus, and also increased lipids, leading to dyslipidemia. And there will be improper regulation of gonadotropins due to improper gonadotropin releasing hormone. So mainly here normally FSH will be FSH and LH will be have normal ratio, but in this condition the luteinizing hormone levels will be increased and follicular stimulating hormone levels will be decreased. Because of this luteinizing hormone level increase, the ovaries will produce more testosterone, more androgens. Because of this luteinizing hormone increase, the ovaries will produce more testosterone, and also because of decreased SHBG, this testosterone will freely circulate in the body and lead to hyperandrogenism. So LH-FSH ratio will be increased, and already I told impaired glucose tolerance test due to insulin resistance leading to type 2 diabetes mellitus. The complications are these patients will have recurrent miscarriages, endometrial cancer will be seen in severe PCOD cases in around 30 years. In third decade, and also you will see endometrial cancers, sleep apnea due to obesity, and cardiovascular disease due to hyperglycemia and dyslipidemias. Cardiovascular disease and hypertension will be seen, and metabolic syndrome. Metabolic syndrome is nothing but obesity, and in type 2 diabetes mellitus, impaired the dyslipidemias, that is high HDL levels will be decreased and triglyceride levels will be increased, and other bad cholesterol like LDL will be increased. So dyslipidemias, obesity and type 2 diabetes is called metabolic syndrome. So these miscarriages, endometrial cancer, sleep apnea, cardiovascular disease and metabolic syndrome are complications. So now we have seen clinical features, pathophysiology and complications. Now we will come to the differential diagnosis. So before differential diagnosis, how to diagnose this is, in USG there will be ovarian cysts, and there will be increased free testosterone, there will be glucose tolerance, means there will be hyperglycemia, dyslipidemia, increased free testosterone, and LH-FSH ratio will be increased. After investigations, now we should also do some investigations to rule out the differential diagnosis, to rule out other conditions which mimic these clinical features of polycystic ovarian disease. That is, differential diagnosis is to rule out other hyperandrogenic states. We should rule out other hyperandrogenic states like adult onset 21 hydroxylase deficiency, which is a non-classic congenital adrenal hyperplasia. Here also there will be increased androgens because this adrenal, in this 21 hydroxylase deficiency, the cortisol and aldosterone levels are not synthesized, but the androgens are synthesized more, like DHEA and other androgens from adrenal gland will be synthesized more. So it's a type of hyperandrogenic state. So it should be ruled out. For this 17 hydroxyprogesterone level should be measured, and other conditions like androgen secreting adrenal or ovarian tumors. So these androgens can be secreted by the tumors from adrenal or ovarian gland. So these tumors should also be ruled out. So non-classical congenital adrenal hyperplasia, that is 21 hydroxylase deficiency, will be ruled out by measuring 17-OHP, and androgen secreting adrenal or ovarian tumors can be ruled out by CT scan or MRI. Differential diagnosis also to rule out other causes of anovulation and infertility. So as these patients also will present with anovulation and infertility, other causes of this infertility and anovulation should also be ruled out, like hyperprolactinemia, premature ovarian failure. Premature ovarian failure means in adolescent or younger children, the ovaries will be failed due to many causes like infections, trauma, or malignancies, etc. So this premature ovarian failure, hyperprolactinemia, and also hypothyroidism, these are the other causes of infertility. So prolactin levels, thyroid hormone levels should be measured to rule out other causes of infertility as a differential diagnosis for polycystic ovarian disease. Next we will come to the management of obese or overweight patients. is first line management is to lose weight. Okay, if the patient is overweight or obese, the first line management is always to lose weight. It is a natural and first line management, because the drugs will always have side effects, because here we are using mostly hormones and other drugs, so these have side effects. So first line management should be natural, and weight loss should be done by exercise and diet. And medical management is combined oral contraceptive pills, like cyproterone acetate and ethinyl estradiol. Combined with oral contraceptive pills contains both progesterone and estrogen. Progesterone component most commonly used are progesterone component is cyproterone acetate and ethinyl estradiol. This is the most commonly used combined OCP. Okay, and metformin and pioglitazone. These are only to be started in patients, in women with amenorrhea, infertility, and in irregular menses, and the patients who are having hyperandrogenic states leading to amenorrhea, infertility, and irregular menses, and patients who want to conceive, who want to be fertile. In these patients, you can start oral contraceptive pills, metformin and pioglitazone, who have amenorrhea, infertility, and who want to conceive, and who have irregular menses and severe clinical features of PCOD. Okay, because these combined oral contraceptive pills, they have side effects of complications of thrombosis, deep vein thrombosis, and stroke. So they should be started only in first line management, like weight loss and everything, diet control and weight loss is exercise. After that, then if they need a contraception, if they need conceive, or if the symptoms are severe, then only these combined OCP should be started. These oral contraceptive pills will prevent endometrial hyperplasia and cancer also. So these combined oral contraceptive pills act by reducing free testosterone, and also they reduce free testosterone by increasing the SHBG, sex hormone binding globulin. They increase the sex hormone binding globulin and reduce the free testosterone. They also suppress luteinizing hormone and dihydroepiandrosterone. Okay, they also suppress this and will help to reduce the hyperandrogenic state. Okay, if the conditions, if the hyperandrogenic state is not so severe, and if the patients does not want to conceive immediately, then you can use only periodic use of oral progestins can be used, and no need to use combined oral contraceptives, because they have side effects like DVT and stroke. If the problem is not so severe, and if they don't want to conceive, then only periodic use of only oral progestins can be used to prevent the endometrial hyperplasia in mild cases. So as the complication is endometrial hyperplasia and endometrial cancer in these PCOD patients, so if the disease is not so severe, instead of combined oral, first line is weight loss. If the disease was not so severe, instead of combined oral contraceptive pills, endometrial hyperplasia, to prevent endometrial hyperplasia, only periodic use, not continuous, periodic use of oral progestins can be used in mild cases. Okay, and metformin and pioglitazone also reduce insulin resistance. These reduce insulin resistance. These are anti-diabetic medicines. They reduce insulin resistance. As you know, if you reduce insulin, the SHBG levels will increase. As you seen in pathophysiology, these SHBG levels will increase. This leads to decreased free testosterone. This leads to ameliorate the problem of this hyperandrogenism. Okay, these metformin and pioglitazone also should be used in patients with who want to conceive and who have severe disease. Okay, they are also not used routine, only who want to conceive and who have severe disease. So this combined OCP and metformin and pioglitazone should be used who want to conceive and who have severe amenorrhea and irregular menses, then only you should use with severe disease. Otherwise, no need. Only periodic use of oral progestins is sufficient to prevent endometrial cancers. Only periodic use to prevent the endometrial cancer and hyperplasia in mild cases. Okay, and anti-androgens like cyproterone acetate and spironolactone 5-alpha reductase inhibitors like flutamide and finasteride can be used in women with severe hirsutism. With severe hirsutism, acne is there, means then you can use these anti-androgens like cyproterone acetate, spironolactone 5-alpha reductase inhibitors like flutamide and finasteride, okay, with severe hirsutism. Otherwise they should not use okay, because they have side effects like the cyproterone acetate has side effects like liver tumors. Okay, otherwise in mild cases vaccine, laser therapy and electrolysis are recommended. Okay, this is about PCOD. If you have any doubts, please comment in my comment box, and if you like this video, please like the video and press the like button, and if subscribe to my channel. Thank you very much.